Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit Das, currently JR2 in the Department of Pharmacology, IMPLIED, and I am back with one of my tutorials. So in today's tutorial, I will be talking about the anti-anxiety agents and the antidepressants, and this is basically a tutorial for the Bsc nursing students, Bmlt students, and the Bsc Ott students. So without wasting any time further, let's get into today's video. So in today's video, I will be discussing anti-anxiety agents and antidepressants under the following headings, as you can see here. First, we will be describing what is anxiety and depression. So basically, this is to get a general understanding of what anxiety means and what depression means. And following that, we will be discussing about the pathophysiology and how we are going to target that using the drugs. Then we have the anti-anxiety agents, that is anti-anxiety drugs, and then we have the antidepressants. So first, let's discuss what is anxiety and depression. So anxiety is basically excessive worry, and this is actually not anxiety, this is actually excessive worry and fear and apprehension which lasts for more than 6 months, and it is something which the person finds difficult to control on its own. Okay, so anxiety is basically excessive worry which persists for more than 6 months and it is difficult for the person to control it. Then we have depression. So depression is a constant feeling of sadness and loss of interest from the activities which the person was interested earlier on, and this stops the person from doing the normal living activities. And in the severe cases of depression, the person will also have suicidal tendencies. So what is depression? Depression is basically constant feeling of sadness and loss of interest, and it stops the person from doing the normal activities, and in case of severe forms of depression, the person will also have suicidal tendency. Now here you can see in this image we are having the different features of anxiety and depression, and there are some features which are overlapping in this case. So that is basically it is the feature of both anxiety and depression. So anxiety and depression are having some common features. So as you can see here, in both the cases you will have restlessness, then there will be trouble in thinking and concentrating and to make decisions in both the cases. Then the person will have excessive worries, as in case of anxiety, because anxiety itself means excessive worry, and in depression also the person will have excessive worries. Then unexplained physical complaints such as headache or stomachache is seen in case of anxiety and depression, and the person will be agitated. So these all features are seen both in anxiety and depression. Now coming to the features which are seen more commonly in depression. So here we have frustration, then the sadness, the feeling of worthlessness, then irritability, loss of interest from the normal activities, then the thoughts of suicide or death, that is in case of severe forms of depression, fatigue, then disturbance in sleep or appetite, that is the person might lose the appetite also, so it is a case of anorexia also. Then in case of anxiety we get some other features which are not seen in depression, like first we have trembling, that is in the form of tremors. Then the person might have increased breath rate or increased heart rate also, because the person is anxious. Then feeling nervous or powerless, like person will be not be able to do the things, and he will think himself as incapable of doing some things. Then having a sense of impending danger or panic. Then elevated heart rate, as I have already mentioned, that is respiratory rate will be increased, heart rate will be increased, that is heart rate is nothing but the pulse rate. Then sweating, that is the features which are seen in case of anxiety but not in depression. And we have some common features, that is restlessness, excessive worrying, then we have agitation, inability to concentrate and make proper decisions, then some of the unexplained physical complaints like headache, stomachache, etc., which are seen in both anxiety and depression. So this is in short about anxiety and depression, like the basic understanding which you need to know before we go into the drugs. Now coming to the pathophysiology of anxiety and depression. So in both anxiety and depression there is an important role of neurotransmitters. So there are problems in the neurotransmitter which leads to the development of anxiety and depression, and also there are some other factors like genetic factors, then we have stress and several other factors which leads to the causation of anxiety and depression. So the neurotransmitters, under neurotransmitters we have norepinephrine and serotonin. So these norepinephrine and serotonin, these are the two neurotransmitters which are involved in both anxiety and depression. So there will be issues in these two neurotransmitters in both anxiety as well as in depression. So let's see. First, low serotonin system activity and elevated noradrenergic activity are considered responsible for the development of anxiety, which is very common. That is it is the less levels of serotonin, that is 5-HT, as I've already mentioned, serotonin. If it is less, it leads to development of the anxiety. And then we have elevated noradrenergic activity, that is increase in the norepinephrine, because of this the person will be having sweating, then there will be increase in the heart rate, palpitation, respiratory rate will be increased, all those things. So therefore, for the management of anxiety, we have selective serotonin reuptake inhibitors, that is SSRIs, and as a result it will increase the level of serotonin in the synapse because it is not being reuptaken. And also we have serotonin norepinephrine reuptake inhibitors, that is it will also again increase the concentration of the serotonin in the synapse. So these are the first line agents for the management of anxiety, that is SSRIs and SNRIs. Now, what is the cause for depression? So a depletion of the neurotransmitters like the serotonin, as I have already mentioned, serotonin again involved here. Then we have norepinephrine again involved in depression. Apart from that, we also have dopamine and brain-derived neurotropic factors. So this BDNF, the norepinephrine, serotonin, and dopamine. So depletion of these neurotransmitters in the central nervous system may be the factor for the causation of depression. So for the management of depression, what we do is we will again use selective serotonin reuptake inhibitors, that is SSRIs, or else we can use serotonin norepinephrine reuptake inhibitors. This will also increase the levels of serotonin in the synapse. Also it will increase the levels of norepinephrine also. And then we have monoamine oxidase inhibitors. These are also used because these actually cause the degradation of the neurotransmitters which are involved here, that is serotonin, norepinephrine, dopamine. So it will prevent the degradation because it is inhibiting the monoamine oxidase enzyme. So all these can be used for the management of depression. So this was basically about the pathophysiology of anxiety and depression. So in both the cases, we have seen that we can use selective serotonin reuptake inhibitors. We can also use serotonin noradrenaline reuptake inhibitors or norepinephrine reuptake inhibitors. And in case of depression, we can also use monoamine oxidase inhibitors. And serotonin and norepinephrine are the neurotransmitters which are involved in both the cases, that is both in anxiety and as well as in depression. Now let's discuss the anti-anxiety agents. So in anti-anxiety agents, first we can see there are SSRIs. So SSRIs, I will be discussing it in the detail in the upcoming slides, that is in the depression part, that is in the antidepressant agents. We will be discussing SSRIs in detail. Apart from SSRIs, we are also having serotonin and noradrenaline reuptake inhibitors, that is venlafaxine. Example of SNRI is venlafaxine. So these are the preferred agents for most of the anxiety disorders, but it is not used in case of acute anxiety. Why? This is because it takes time for the response to occur when we are giving the individual either SSRI or SNRI. So that is the reason why these cannot be used in the management of acute anxiety. As you can see here, the response is delayed in the case of these drugs. Then we have the next group of anti-anxiety agents, that is benzodiazepines, that is BZDs. Under this we are having the examples like chlordiazepoxide, then we have diazepam, then we have lorazepam, then we have oxazepam, then we have alprazolam. All these can be used as anxiolytic agents. Anxiolytic agent means basically to decrease the anxiety, and they act on the limbic system and facilitate the inhibitory effect of GABA. Okay, that is basically they are promoting the action of GABA. And what does GABA do? GABA helps the brain process the information more slowly. So as a result, it will prevent the anxiety because it decreases the function of the brain. That is, it is actually calming the individual. It is having a calming effect. This GABA is having a calming effect, and benzodiazepine is actually facilitating the inhibitory effect of this GABA. So by this way, it decreases the anxiety and hence it prevents anxiety. So benzodiazepines are mainly useful for short-term treatment of anxiety. They act rapidly and are most commonly used for acute anxiety. Why? Because they act rapidly, so they are used in case of acute anxiety where we cannot use SSRI and SNRIs. And the adverse effect of benzodiazepine includes sedation, then we have impairment of memory, then we have confusion, and also dependence, that is depending on the benzodiazepine for the effects later on. It can be either in the form of physical dependence or it can be in the form of psychological dependence also. So we have covered two groups, that is SSRIs and SNRIs, and following that we have also covered the benzodiazepines. Now let's move on to the next groups. So next is buspirone. So it is basically a partial agonist of 5-HT1A receptor, and it causes selective anxiolytic effect because it stimulates the 5-HT1A receptor. So as a result, it is having the effect of the serotonin. So as a result, it will be causing the anti-anxiety effect. But it is not going to have the side effects which we are seen, which we have seen in case of benzodiazepines, that is no sedative action is seen. Then also it is not going to cause any anticonvulsant effect, so it cannot be used as an anticonvulsant just like how the benzodiazepine is being used. It can also be not used as muscle relaxant. So benzodiazepines can be also used as muscle relaxant. They can also be used as an anticonvulsant. They can also cause sedation. But buspirone doesn't cause any sedation, doesn't have any anticonvulsant activity, doesn't have any muscle relaxant activity. And it also produces an effect which is delayed. So here also the effect is delayed. So it takes about 2 weeks to fully develop. That is, the 2 weeks are required for the development of the effect following the administration of buspirone. So again, it is not effective in case of acute anxiety, that is acute anxiety. In that case, we are not going to use buspirone. Next, we have beta blockers. Under beta blockers, we have propranolol and other non-selective beta blockers. They are basically used to reduce the symptoms of anxiety. So what we have seen in anxiety, that is the person will be having increased heart rate, that is tachycardia, then palpitation, tremor, and sweating. So for this we are using beta blockers. So it is actually not going to act on the pathophysiology directly, but it is actually controlling the symptoms of anxiety. So that's why we can use non-selective beta blockers like propranolol for the management of the symptoms of anxiety. Next, we have the H1 blocker, that is hydroxyzine, which is a highly sedative first generation H1 blocker, and it is having a selective anti-anxiety action. That's the reason why it is also used as an anti-anxiety drug. So under anti-anxiety agents, we have seen the following groups, that is SSRIs, then we have seen SNRIs, then we have seen the benzodiazepines, following that we have seen the buspirone, which is 5-HT1A agonist. Then we have the beta blockers, which are used for managing the symptoms of anxiety, and it is not actually going to target the pathophysiology. Then we have H1 blocker, that is hydroxyzine, which is having a selective anti-anxiety action. So with this, we are completing with the anti-anxiety agents and the groups which are coming under anti-anxiety agents. Now, let's discuss about the nursing implications related to the use of these anti-anxiety drugs. And this is actually meant for only the Bsc nursing students. So if you are a Bmlt student or a Bsc Ott students, then you can skip this part and go on to the next slide. So related nursing implications, as you can see in case of anti-anxiety agents, are we had to advise the patient to avoid driving and working with heavy machinery, as sedation can occur with the anti-anxiety drugs. As you can see that there was H1 blocker, that is hydroxyzine, and also the other drugs like benzodiazepines which cause sedation. So when the person is on such kind of anti-anxiety drugs, we need to advise the patient to avoid driving and to avoid working with heavy machinery because it can lead to injury. Then the person needs to avoid alcohol and other CNS depressants while on anxiolytics. This is because anti-anxiety drugs are already causing CNS depression, and if the person is on alcohol or other CNS depressants, then it will lead to severe depression of the CNS, which we don't want. Next, we should also suggest the patient's relaxation techniques, and also the counseling sessions have to be provided to the patient which act as the non-pharmacological management of anxiety. So this has to be suggested to the patients, that is relaxation techniques, and the counseling sessions have to be provided to the patients with anxiety. Now let's get back to the main topic again, that is the antidepressant. So antidepressants, under antidepressants we are having the following classes. First is reversible inhibitors of MAO-A, that is monoamine oxidase A inhibitor. Under this we have moclobemide, that is reversible inhibitor. Then we have another drug, that is clorgeline, which is an irreversible monoamine oxidase A inhibitor, which can be also used as an antidepressant because monoamine oxidase are responsible for causing the degradation of the neurotransmitters like the norepinephrine, then we have the dopamine, then serotonin, which are actually needed for showing the antidepressant effect, and it is their decrease in concentration which leads to depression. So we are using monoamine oxidase inhibitors, and then following that we are having selective serotonin reuptake inhibitors, that is SSRIs. Basically these are the mainstay drugs, that is the first line drug for the management of depression. Under this we have the following drugs, that is we have fluoxetine, then we have fluvoxamine, then we have paroxetine, sertraline, citalopram, escitalopram, dapaxetine. So it is very important to remember all these drugs. Fluoxetine, definitely you have to remember this, then fluvoxamine, then citalopram, escitalopram, sertraline, all these drugs have to be remembered. Then we have next class, that is TCAs, that is tricyclic antidepressants. So for this we have two different types of TCAs, that is one which inhibits the noradrenaline and the serotonin reuptake, that is it is going to inhibit the reuptake of noradrenaline and serotonin. And next, the another TCAs are those which are predominantly inhibiting the noradrenaline reuptake only. So first case, that is noradrenaline and serotonin both, and then the second part only the noradrenaline. So under this we are having imipramine, then we have amitriptyline, then we have trimipramine, then we have doxepin, then we have dothiapine, then we have clomipramine. Then under this, that is predominantly noradrenaline reuptake inhibitors, we have desipramine, nortriptyline, and amoxapine. So these all can be remembered with the mnemonic, that is anti-Depsy. So from A we can get amitriptyline, then from N we can get nortriptyline, then from T we can get trimipramine, then from I we can get imipramine, then we can get doxepin and dothiapine by D. For E and P we don't have any drugs as such. Then we have C, that is for clomipramine. So if you remember antidepsy, you can remember these drugs, the name of these drugs. Then next group we have is serotonin and noradrenaline reuptake inhibitors. It is also the first line agent for the management of antidepressant. Under this we are having venlafaxine and duloxetine. So SSRIs and SNRIs, these are basically the first line agents for the management of depression. Also these are the first line agent for the management of anxiety, only not in case of acute anxiety where we use benzodiazepines. Now we have atypical antidepressants. Under this we are having the following drugs, that is the trazodone, then mianserin, mirtazapine, and bupropion. So typical depressants are SSRIs and TCAs, that is tricyclic antidepressant and selective serotonin reuptake inhibitors. They work by increasing the levels of serotonin and norepinephrine, while these atypical antidepressants have multiple actions, that is multiple mechanism of actions. So one such example is bupropion. As you can see here, bupropion, what it does is it binds to the dopamine transporter, that is DAT, and also to the norepinephrine transporter, that is NET, and hence it reduces the reuptake of these neurotransmitters back into the neuron and increases the concentration of both dopamine and norepinephrine in the synapse, and as a result it reduces the antidepressant effect. So this prolongs the duration of action of these neurotransmitters in the synapse because of this. So atypical antidepressants act by several other methods apart from increasing the levels of only serotonin and norepinephrine in the synapse. It can also increase the levels of dopamine also. So this is about the classification of the antidepressants. Now let's go to the first class, that is the tricyclic antidepressants. As you can see in this image actually depicts the proper mechanism of action of the tricyclic antidepressants. So here you can see the neuron, and then we have the effector cell. This is the effector cell, and this is the presynaptic neuron. So norepinephrine is being released from the presynaptic neuron, and tricyclic antidepressant, it is basically going to inhibit the norepinephrine transporter, that is NET, and because of this there is increased concentration of norepinephrine in the synapse because it is not taken up back. So this way it produces the antidepressant effect. Also we can see tricyclic antidepressants which also inhibits the serotonin transporter, that is SERT, and as a result there will be increase in the concentration of the serotonin in the synapse, leading to antidepressant effect again. So both these mechanisms are very similar, that is TCA will inhibit the transporters, that is norepinephrine transporter, that is NET, and then we have the serotonin transmitters, that is SERT, and as a result there will be increase in the concentration of serotonin, that is 5-HT, and norepinephrine in the synapse, because of which it will show the antidepressant effect. Then this tricyclic antidepressant also have atropine-like action, that is, it causes muscarinic blockade, because of which the person will also have some of the side effects like dryness of mouth, then we have blurring of vision, constipation, and it may also precipitate glaucoma. Then it also causes alpha 1 receptor block, that is alpha 1 adrenergic blockade, because of which the patient can have postural hypotension, and because of the hypotension, that is decrease in the blood pressure, there can be reflex tachycardia also, and also there can be cardiac arrhythmias. Also, TCA cause H1 blockade leading to sedation and confusion, just as seen in case of H1 blockers. And one more thing, that is it lowers the seizure threshold, that is tricyclic antidepressant lowers the seizure threshold, and as a result it will precipitate the convulsions, therefore it is contraindicated in epileptics. And all the types of depressants, usually all the types of depressants will take at least 2 to 3 weeks to produce the beneficial effects. So this is about the tricyclic antidepressants and how they act. There is basically, first they will cause the increase in the levels of norepinephrine in the synapse. They can also cause the increase in the levels of serotonin in the synapse, and they will cause side effects, that is by causing the muscarinic blockade, and it will show atropine-like action. They will also cause the alpha 1 blockade, then that will lead to postural hypotension leading to reflex tachycardia, arrhythmias, etc. They will also do the H1 blockade leading to sedation, and also they are going to decrease the seizure threshold leading to precipitation of the convulsions. So these are the actions of the tricyclic antidepressants and why it causes the following adverse effects. As you can see here, these are the adverse effects. Now let's go into the pharmacokinetics. So tricyclic antidepressants are well absorbed through the gastrointestinal tract, and then they are widely distributed in the tissues including the central nervous system. It is metabolized in the liver. Some of them like imipramine and amitriptyline produce active metabolites which are responsible for the longer duration of action of these drugs. That is, imipramine and amitriptyline will be converted into active metabolites, and as a result this will prolong the duration of action of these two drugs. And these drugs are excreted mainly in urine. So this is about the pharmacokinetics, that is absorbed from the GIT after oral administration, then it is getting widely distributed, reaching the CNS, getting metabolized in the liver, getting excreted by the via the urine, and some of it is converted into active metabolites which will lead to increase in the duration of action of those particular drugs, that is imipramine and amitriptyline. Now coming to the adverse effects and contraindications of the tricyclic antidepressants. First, coming to adverse effects. So as you can see here, one, that is muscarinic blockade. So in that case we will get atropine-like side effects, that is, as you can see here, dry mouth, then the patient will have constipation, then there will be urinary retention, then there will be blurry vision, all the things which are seen in case of atropine poisoning. Then other adverse effects include postural hypotension leading to reflex tachycardia and cardiac arrhythmias, which are due to the alpha 1 blocking activity of the tricyclic antidepressant, and also because H1 receptors are blocked, it leads to sedation and confusion. Apart from this, there are some other side effects like increased appetite, weight gain, and it also precipitates the convulsions, that is by lowering the seizure threshold. So from this only we will get the contraindications. As you can see here, the contraindications of tricyclic antidepressants: it is not used in patients with epilepsy because it decreases the seizure threshold leading to precipitation of convulsions. Next, it should not be used in ischemic heart disease because it also causes arrhythmias, it causes tachycardia, so it can even precipitate the ischemic heart disease. Next, since it causes urinary retention already, so it should not be used in individuals who are having enlarged prostate, because in that case already the patient will be having urinary retention. And also another contraindication is that it should not be used in patients with glaucoma. So the contraindications include glaucoma, then we have epilepsy, then we have ischemic heart disease, and then we have enlarged prostate. So these are the contraindications of tricyclic antidepressants. Now coming to the next class, that is the selective serotonin reuptake inhibitors and serotonin and noradrenaline or norepinephrine reuptake inhibitors. So these are the first line agents for the management of anxiety and also for the management of depression. So how are they going to act? First, let's see this diagram. As you can see, this is a presynaptic neuron and this is the postsynaptic neuron, and in the presynaptic neuron we are having the vesicles which contain the neurotransmitters. That is, as you can see here, from the blue dots it is representing the serotonin and the red dots are representing the norepinephrine, and these are being released from the synaptic vesicles into the synapse, and then it binds to the receptors which are seen here. So if the concentration of the serotonin and the norepinephrine increases in the synapse, then only it is going to produce the antidepressant effect. So how are we going to do that? That is by inhibiting the transporters. As you can see here, these are the serotonin transporter and these are the norepinephrine transporter. So these are responsible for causing the reuptake of the neurotransmitters back into the presynaptic neurons. So we will be inhibiting this with the use of SSRIs and SNRIs, and as a result there will be increase in the concentration of both serotonin and norepinephrine in the synapse, leading to antidepressant effect. So this is what is being explained in this paragraph. So as you can see, SSRIs inhibit the serotonin transporter, so it blocks the reuptake of 5-HT into the presynaptic neuron, leading to increased availability of the serotonin at the receptor site, that is in the synapse in the CNS, and hence it increases the serotonergic effect. Then we have SNRIs, which inhibits the presynaptic neuronal uptake of 5-HT, that is serotonin, and also the norepinephrine following the release in the synaptic plate. That is, once this serotonin and the norepinephrine is released in the synaptic plate, it is prevented from being reuptaken by SNRIs. So both these classes have no anticholinergic effects, no sedation, no weight gain, and no precipitation of seizures, which was seen in case of tricyclic antidepressants. And that is the reason why it is better than the tricyclic antidepressant, because it doesn't have these anticholinergic effects, doesn't have the sedation problem, doesn't have the precipitation of the seizures problem, doesn't have the weight gain adverse effect. And the common adverse effects for both these classes, that is SSRIs and SNRIs, include nausea, vomiting, and sexual dysfunction, and also it can also lead to loss of libido in case of males. So the common side effects include nausea, vomiting, and sexual dysfunction. So these side effects have to be remembered. Okay, now let's come to the next class, that is the monoamine oxidase inhibitors, which are also used as an antidepressant. As you can see, so the mechanism of action is very similar. That is, it will prevent the metabolism of noradrenaline, that is norepinephrine. It will prevent the metabolism of serotonin and tyramine, because this enzyme, that is monoamine oxidase A, and then we also have a type, that is monoamine oxidase B, which are actually responsible for metabolism of these neurotransmitters. So if we prevent the metabolism of these neurotransmitters, their concentration increases in synaptic cleft, that is increased concentration of Na and 5-HT in the synaptic cleft, leading to antidepressant effect. So very simple mechanism, that is preventing the metabolism of the neurotransmitters, leading to antidepressant effect. So with the use of monoamine oxidase inhibitors, we need to know about a particular reaction that is called as the cheese reaction. So what is cheese reaction? That is when a patient is on monoamine oxidase inhibitor, and if the patient consumes the food which are rich in tyramine, that is in case of cheese, then we have fish, then we have meat, beer, wine, yeast. All these are rich in tyramine. Then in that case, it will lead to fatal hypertensive crisis in the individual and cerebrovascular accidents, which is nothing but cheese reaction. So what occurs is basically this monoamine oxidase inhibitors inhibits the monoamine oxidase, which is responsible for metabolizing one of the neurotransmitters, that is tyramine. And if we give these food items which are already rich in tyramine, then in that case what will happen? There will be increased levels of tyramine. So tyramine concentration will increase drastically. And then this tyramine, what it does is it enters into the systemic circulation and then gets absorbed into the neurons. And then what it does, it displaces large quantities of noradrenaline from the vesicles of the sympathetic nerve endings. That is, tyramine will displace the noradrenaline from the synaptic vesicle which are present in the neuron, and it will be leading to release of noradrenaline in high amounts. And because of increased release of noradrenaline, it will lead to increased BP, noradrenaline leading to hypertensive crisis, and also it will cause cerebrovascular accident. So it is a very drastic reaction which is called as cheese reaction. And since here the increase in BP is because of the increase in the noradrenaline, so it basically acts via the alpha-1 receptor by stimulating the alpha-1 receptor. So for managing cheese reaction, we use intravenous phentolamine, which is basically an alpha blocker, so as to decrease the hypertension. So this is one reaction which we need to know in case of monoamine oxidase inhibitors, that is the cheese reaction, very important. And how it is being managed, that is by using the intravenous phentolamine. Next is serotonin syndrome. What is serotonin syndrome? So suppose if we do a concomitant administration of SSRI, that is selective serotonin reuptake inhibitors, and monoamine oxidase inhibitors, then what it does is it produces several severe undesirable effects like tremor, restlessness, muscle rigidity, hyperthermia, sweating. shivering, seizures, and coma because of the increase in the concentration of serotonin in the synapse. Because SSRIs will prevent the reuptake of serotonin, and on the other hand, monoamine oxidase inhibitors will prevent the metabolism of the serotonin, leading to increase in the levels of serotonin in the synapse. And because of this, it will lead to the following effects, that is restlessness, tremors, muscle rigidity, hyperthermia, sweating, that is known as serotonin syndrome. And apart from these two reactions, that is serotonin syndrome and cheese reaction, monoamine oxidase inhibitors are also implicated in causing some of the other adverse effects like insomnia because of increasing the levels of serotonin, then dizziness, nausea, etc. Now let's go to the other antidepressants, that is the atypical antidepressants. Under this we have bupropion, which inhibits the reuptake of dopamine and noradrenaline into the neuron. As a result, this increases the concentration of these neurotransmitters in the synapse. So this will have the antidepressant effect. Also, bupropion is used for smoking cessation. Then we have mirtazapine, which is belonging to the class called as noradrenergic and specific serotonergic antidepressant, that is NASA. It blocks alpha 2 autoreceptors on the noradrenergic neurons. And as you know, alpha 2 receptor in the presynaptic neuron is an autoreceptor which, when stimulated, it leads to decrease in the release of the neurotransmitters like noradrenaline. So if we block it, it will lead to increase in the release of neurotransmitters like noradrenaline and serotonin, and hence it will also produce the antidepressant effect. Now we have trazodone, which has a very simple action, that is it blocks the 5-HT reuptake just like the selective serotonin reuptake inhibitors, leading to increase in the concentration of serotonin in the synapse, and as a result it will produce the antidepressant effect. Then we have mianserin, which increases the noradrenaline release by blocking the presynaptic alpha 2 receptors. Again, the same mechanism of action as seen in mirtazapine, that is autoreceptors are blocked, leading to increase in the release of the noradrenaline from the presynaptic neuron. And all these drugs, that is mirtazapine, trazodone, and mianserin, all these three drugs are having sedation as a common adverse effect. So this you can remember, that is sedation is a common adverse effect for both for all these three drugs, that is mianserin, then we have trazodone and mirtazapine. So this was about the atypical antidepressants. Now let's go into the next slide, that is the uses of antidepressants. So as you can see, it can be used for depression, that is it is used for endogenous depression and in depressive phase of bipolar disorders. That is, in bipolar disorder we are having mania and depression both. So in the depressive phase we can use the antidepressants. So SSRIs are preferred more than the tricyclic antidepressants, as you know already. This is because of the better tolerability of the SSRIs, less side effects of SSRI, because it doesn't have that anticholinergic effects which are seen in case of tricyclic antidepressants, and also because of the longer duration of action of SSRIs. That is the reason why SSRIs are preferred over tricyclic antidepressants for the management of endogenous depression and also the depressive phase of bipolar illness. Next, SSRIs and SNRIs are also used in panic attacks, phobias, and generalized anxiety disorder. As I have already mentioned, these are also the first line drugs for the management of anxiety disease. And then we have SSRIs like fluvoxamine and fluoxetine, which are used in obsessive compulsive disorder, where the person is having obsession and the compulsive activities. Then we have tricyclic antidepressants like imipramine and nortriptyline, which are used in ADHD, that is attention deficit hyperactivity disorder. Then TCAs are also used in the management of neuralgia, that is pain associated with the nerves. Then these tricyclic antidepressants are again used for the management of nocturnal enuresis, that is basically the bedwetting. And bupropion, as I have already mentioned, it is also used for smoking cessation. So these are the different uses of antidepressants. Apart from depression, they can be also used for the management of obsessive compulsive disorder, then generalized anxiety disorder, attention deficit hyperactivity disorders, then neuralgia, nocturnal enuresis, that is bedwetting, and also can be used in smoking cessation as in case of bupropion. Now coming to the related nursing implications for the use of antidepressants. So this is mainly for the nursing students only. First, instruct the family members to administer the drug as prescribed by the doctors and to monitor the intake of the drug by the patient, because in some case the patient might not take the drugs. Next, educate the patient and also the family about the fact that antidepressant effect presents only after 2 to 3 weeks of starting the therapy. That is, we will not get the antidepressant effect immediately after starting the therapy. Next, Patient and family members are also asked to contact the treating doctor before taking any other medication. This is to prevent the drug-drug interactions which are seen with the use of these antidepressants. Next, advise the patients to avoid foods like yogurt, beer, to prevent cheese reaction which is seen in case of usage of monoamine oxidase inhibitors. So these are the nursing implications related to the use of the antidepressants. Now finally coming to the conclusion, anti-anxiety agents and antidepressants both are related strongly to two different neurotransmitters, that is serotonin and norepinephrine. So the pathophysiology and the treatment based on the drugs are mainly revolving around these two neurotransmitters, that is 5-HT, that is serotonin, and NE, that is norepinephrine. So this is about the management of the anxiety and the depression, that is the pharmacology management. So with this I would like to end this tutorial. I hope you liked this tutorial. So if you like my content, please do like, share, subscribe, comment, and also press the bell icon so as to get notified whenever I upload a new video. Thank you guys.
They tell me that I'm never gonna make it.